In the AV department, it's actually the owner of that room right now. Those rooms is AV.
Okay.
All right.
Is it recording?
Yeah.
Hello, everybody. I'm Joanne, and this is the first Nursing Grand Rounds for 2019, sponsored by the Nursing Council. We are so happy to see all your faces. If another time that we offer this, we are doing video so you can get it from home or on your phone, and I sent that information out so you can sign up for that. But today I'd like to introduce Dr. Glenn Stryjewski. I probably verbalized his name. But he comes with, he's been here since 2015. He comes with a very robust history in education, and we're really glad to have him here. He has a BS in biomedical engineering from Johns Hopkins. He got his MD from New York and Brooklyn. He has a master's in public health. What don't you have?
I'm working on my MBA right now.
Okay, and he's working on his MBA. But I think the most interesting thing, besides being a pediatric intensivist here, is that he has an interest in simulation education. Anybody in PEDS has seen him or PALS or worked with him in PALS. He serves as the president of the board of directors for the Canine Partners for Life, an organization that trains service dogs. So we'll get him back to talk about that another time. So, but today he's going to talk about recognition of the sick child, and then we'll talk about
nursing grand round,
adult versus pediatric disease.
The speaker is Dr. Glenn.
Well, she's got to say my name twice, so it's going to take a few minutes to get through.
The topic is recognition of the sick child. These discussions on adult versus pediatric disease. Your attention, please. Nursing grand rounds are now beginning in conference room 2. The speaker is Dr. Glenn Stryjewski. Topic is recognition of the sick child. Case discussions on adult versus pediatric disease.
Okay. So hi, I'm Glenn Stryjewski. I know most of the back row. There's a couple of actual pediatricians in the room, so they can correct me if anything that I present here is wrong. I'm one of the pediatric intensivists. I felt that this would be attended by a majority of adult providers primarily, so it's sort of geared towards pointing out some of the differences in pediatrics. We have this disclosure and contact hour statement they have to include, so for nurses in the audience and doctors in the audience who get some credit for it. I myself have no conflicts of interest to disclose. And I want to apologize if they got a pediatrician to do this, because I'm sure that most of you don't deal with this in a regular basis. So my objectives. Is there a way to advance the slides other than hitting my keyboard? There's no clicker.
I don't have one now.
Okay, all right. So we're going to talk about, so there's a famous saying that children are not just little adults. In most cases, they actually really are, but in some cases, they're not. So we're going to point out some of the places where they're not little adults. And what I thought was interesting is to discuss, especially for providers who primarily take care of adults, some differences in kids, some disease states in kids that you may never see or may never even think of. I want to identify differences in adult versus pediatric disease, and then we're going to have some case discussions at the end where we can talk about some of those things that we learned along the way. So my first question is actually, who's in the room? So I really know most of the back row, but where do you work?
I am in nursing education here.
Okay.
My name is Stacy, and I used to be in day surgery, but now I do. I'm the education and simulation coordinator for nursing.
Oh, nice to meet you.
Nice to meet you.
A lot about you. Nice to meet you. I know that's a pediatrician. How is this middle row? Where do you guys work?
Yeah.
You all right?
Yeah.
You're all right. All right. So we're not going to go around the room, but I assume everyone else primarily cares for adults, and that's good. The ER, I'm so glad you guys are here because I would love to be for us to help be a resource for pediatrics in the ER. I know you guys don't see kids very often. I am sure when a kid rolls through the door, especially a sick kid, no one's really loving that assignment. No one's really running to that assignment. Same way if you threw an 80-year-old with a heart attack, I want nothing to do with it. But we can help educate and help you learn some stuff. So we'll start with the airway. So being a PICU doc, I have to control the airway of pediatrics, and it's a little bit difficult. There's a lot of anatomical differences in the pediatric airway that make them not really want to breathe well. It's actually I marvel as I've learned through my pediatric education that we are the dominant species on Earth, because little babies have so many anatomical problems, and why they survive, I'm not really sure. But one of the biggest problems is that they have these small mouth, small nose, relatively large tongue, which is all meant to obstruct the airway. And we'll talk about when they get even the most simple of diseases, can obstruct their airway very easily. And then when we go to intubate them, their trachea is very anterior and superior. So when you go to intubate someone, you lift up, you want to see the trachea underneath, but a trachea in a kid is high and close to you, and it's much harder to see. So it's much cooler when I intubate someone than when I intubate an adult, basically, is what I'm saying. This is just demonstrating some of the big things, but that big tongue is really a problem. The epiglottis also, so that epiglottis, which is designed to protect your airway in a pediatric patient, it flops into your field of view, whereas an adult it's very stiff. It should lift up out of your field of view. One of the simplest things, again, I'm probably going to talk a little bit to the ER since there's an ER predominance in the room, is kids have a big occiput. You've probably been taught this, right? But you don't think about that so much. I mean, even see on our pediatric floor, we don't necessarily think about it. Kids having trouble breathing, what do we do with every patient? We lay them flat on a stretcher, right? So looking at a kid laying flat on the stretcher with their big back of their head, pushes their airway forward. So if they're having respiratory stress and that big head is pushing their airway forward, they're going to have more problems. They're going to occlude their airway. So it's important to put a shoulder roll under them, even when they're at rest, even when you're not necessarily doing anything. Just opening their airway with that simple procedure can actually save you a lot of heartache for yourselves. Number one. Number two, it's a shoulder roll. You don't want to hyperextend them back. You just want to get under that so that airway opens up a little bit. Okay? And absolutely, I believe the same. Suction saves lives. Okay? I have seen it time and time again demonstrated that just a little, I'm going to use technical terms here, so I apologize if you don't know, please ask me, but a little booger in that nose is going to like close off that airway, okay? So the booger catchers are really important, sucking out that airway. And I can very vividly remember, it was at another institution, but I was literally getting ready to intubate a kid emergently. And the nurse came over with one of these little olive tip catheters, which is designed to fit in the nostril and include to get suction, and pulled out the biggest booger that I've ever seen, and the kid breathed perfectly after that. Gosh. So I've learned a lot over the years. Moving it a step forward, when you're going to maybe control the airway of a pediatric patient, and you're talking about intubating a patient, we always talk about what equipment needs to be around, and suction is a very important equipment. You want to be able to clear suction out of the airway so you can see the airway. This is the famous Yankauer catheter. It's used primarily in most places for suction. These kids with these little mouths, that is actually too big a device to have, and these soft, pliable suction catheters can come into real handy. They're not only when you're going to intubate, but even if you needed to NP or oral suction, these 10, 12, 14 French catheters are really your friend, and are much more useful than the Yankauer, especially in a little baby. Oops, wrong way. Okay. So, breathing. So that's the airway. Again, I'm surprised that the airway was designed by whatever creator, because it's really not meant to help us breathe when we're little, nor is our lungs and our chest wall, okay? So dead space. Dead space is the air you breathe that doesn't take part in ventilation. So it's the air in the nasopharynx, the oropharynx, and the trachea. So when I take a breath in, that's the first air I get in my lungs. And that air has not picked up oxygen or not gotten rid of carbon dioxide. It's dead space. Children, especially infants, have more area in that dead space than adults. So in order to get the same volume, relative volume of oxygenated air, they've got to work harder to get that air volume in and out. They also have not stiff, hard ribs. They have a very compliant chest wall. So, as compared to an adult, I don't know how well you can see this, but, okay, everyone just relax for a second. Take a deep breath and think about what happens to your ribs. And then breathe out. When you did that, what should have happened, didn't go see a doctor, but what should have happened, your ribs should have expanded out when you took a breath in and should have gone contracted when you took a breath out. That's because we have a solid rib cage. Most, especially in the premature infant and the small infant, this rib cage is not solidified. the exact opposite happens. So when the baby tries to breathe in, especially when they're in less stress, they pull down hard, their chest wall collapses on itself, okay? And so I have, now here comes the point where hopefully some video works. Let me see what happens here. Oh, no, that's not me, is it? Oh. Oh, wait. Hey, all right. Oh, it's working on my screen, but not on yours.
F function F8.
F8?
Function F8.
Function F8.
And then either put it on expand or duplicate, whichever it's not on.
Function F8.
She learns this. This happens all the time.
Sound. It's not really killer if it doesn't.
Is this a, wait.
Oh, well.
There you go. You want to go to duplicate.
Oh, hey, cool.
Now you can back it up.
Wow, look at that.
Yours is different.
High tech.
F10.
Okay. I'm going to back it up a little bit. So, if I expand it, it's going to make it bigger?
Yeah.
Oh, yeah, look at that. All right. So, look at this. So, and also, like, the kids come in, like, really cute pajamas and stuff, and they're, like, trying to die. It's great. So, this also shows pretty good. So as that's an inhalation. As this baby's inhaling, everything's like a game, but yet still has a pacifier in his mouth. So that's a good sign that things are going to be okay. Now, think about this is, kids can breathe like this for a long time. They actually can be quite marvelous. And I would judge, if you're looking at this kid, you're going to be like, oh, okay, that's not good. Good. But if they're pretty vigorous, you're probably going to be okay for a little while. They can maintain that level of breathing for a significant period of time. Let's see, how do I get back to
The other.
big?
No, that's all slides.
No, you can go back to the slideshow.
I'm going to need your help again.
I cannot believe I'm actually helping you.
You're doing a fantastic job. No, not at all.
Okay, where's your... Go back and do there as well. I do not know why it does that.
Thank you. So we'll go back.
I just know how to fix it.
Okay, so start with the airway, talk to the chest, start with breathing. Okay. So how do we deliver oxygen? Oxygen is good. Kids hate things on their face. The thing children seem to not mind or mind the least are nasal cannula, right? But I have a pet peeve because I'll get a call from someone and they'll say, I have this kid who's sick and he's on 100% oxygen, okay? So, wow, 100% oxygen, or 100% oxygen and the sats are still low. Okay, that's concerning. 100% oxygen going to that little thing is not 100% oxygen going into the lungs. Sounds obvious, doesn't seem to be obvious to everybody, okay? You probably don't want to give more than about 3 or 4 liters per minute of flow through a nasal cannula. It's very annoying, and if your kid's really agitated, you have that thing jacked up to 6-7 liters, that might be a good reason why. It'll also dry out that mucus a little bit and be a problem for you. They hate masks. This is what's called an oxy mask. It can deliver probably a higher percentage of oxygen, maybe 40-50% of oxygen, but has to have at least 6 liters of flow going through it. Non-rebreather mask, again, this is such a reiteration of PALS, but you can put a non-rebreather mask on a child. People seem to like, kids still hypoxic and they're on this and they don't seem to want to escalate up to this. But absolutely, non-rebreather, but you must have at least 10 liters of flow through here. And then what's represented here is called high flow nasal cannula or Vapotherm, or well, Vapotherm's a trade name. We use different high flow nasal cannula systems. The reason high flow nasal cannula works in kids primarily so well, although I know you use it in the adult population, is because what high flow is designed to do is to wash out that dead space volume. So what we talked about, kids have more dead space volume. It doesn't have a lot of oxygen. It's got a lot of carbon dioxide. High flow washes that out. They don't have to work as hard to move the same amount of effective air into their lungs on that, and that's how high flow works. Okay? Now, if you want pressure, so people say, well, I put high flow because I want pressure. That's hogwash. It doesn't give you a lot of pressure. If you want pressure, you got to give them CPAP or BiPAP. And there are all hosts of different kinds of masks that appropriately fit the child, but you can imagine your average kid doesn't like this strap to their face, right? So the nuance here is how do you get your child who's in respiratory distress to participate in that? And that's not a point of this lecture, but you have to cajole, consider feeding, sedate, do all kinds of things if this is what your child needs, okay? As an undercurrent of all this, we on the pediatric floor are always willing to help, all right? So please, I think I have a slide at the end that has our phone number for help. Or Dr. Jim is always available.
We'll call Dr. Jim.
Okay, so we did airway and deep breathing. Now circulation, okay? So circulation is a little bit different. And we're going to do a little anatomy class here in a minute. But we're going to talk about how kids increase their cardiac output. We're going to introduce something called the physiologic nadir, which you may or may not know about. We're going to talk about the ductus arteriosus, which means we're going to talk about the anatomy of a baby when they come out of the womb and how things change that first couple of days of life. So when you see an infant in your ER, hopefully not too often in surgery, but in the ER who's only 2, 3, 4 days old, that's a different kid. It's a different kid entirely. And because of that, we'll talk briefly about some cyanotic heart anatomy, and we'll talk about intravascular volume. Okay, so I know you're excited to come on this. Oh, by the way, thank you. It is gorgeous outside, so why you people are here at all, I'm not sure. Because if I wasn't the one giving the talk, I don't know if I could bring myself here. So I'm going to bore you with formulas. But in nursing school or medical school, wherever school you went to, you probably learned cardiac output. Cardiac output equals heart rate times stroke volume, right? So in order for the heart to pump blood, it's got to go a certain rate, and each time it squeezes, it pumps out a certain stroke volume. That stroke volume is a function of three things: preload to the heart, or intravascular volume, afterload to the heart, and contractility, okay? So the way to look at it is, if I need more cardiac output, let's say I'm septic, and my body is demanding more cardiac output, I have two choices. I can either increase my heart rate or I can increase my stroke volume. Now, a significant difference here in pediatrics versus adults is adults have these big, well, until they have a heart attack, have these big, healthy, muscular hearts. They can really increase their contractility. Infants and children don't have that. So they are incredibly rate dependent, which is why we see kids come in with heart rates 160, 170, 180. Don't totally get so upset. Number one, they need that to improve their cardiac output. Number two, their myocardium is still so healthy because they're young that they don't mind going that fast. You take your average adult at 180, 190, it's a different story. But your average 6-month-old going 180, it's interesting. But it's all because they can't squeeze harder. They can't put out more stroke volume, so they must increase their heart rate. There are also big bags of water. So this infant is 70, you can't see the numbers probably, but this infant is 77% water versus 50 or 60% in the adult. Why this is important is because in any disease process where there's a lot of volume loss, vomiting, diarrhea, you lose body water very quickly, and since there's not a lot else, that loss is more significant for the child than the adult. And their blood volume, I just want to put number perspective here. So again, this is probably too small. But the term infant has a blood volume of 80 mLs per kilo, where an adult has a blood volume of 70 mLs per kilo. Okay? So take your average 70 kilo adult, multiply that by 70 mLs per kilo, you come up with 4,900 mLs, or 5,000 mLs, or 5 liters of blood volume. That's what we mostly have. Term infant has 80 mLs per kilo, but that term infant may weigh 3 kilos, let's just say. Their blood volume is 240 mLs. So the kid comes to the ER, and some well-meaning pediatrician, like Dr. Noble, not thinking, orders all these lab tests. That blood volume comes up to 60 mLs. That's a quarter of their blood volume, right? So just think about that. There are options. Sometimes you have to make judicious use of prioritizing what tests you're going to order. If you are the nurse caring for the patient, you have to advocate for the patient and be like, Dr. Noble, stop it. Stop ordering so much blood. You're going to extenuate the patient, okay? Sorry, Eric. I know you never do. I already picked on Anna. So. Okay, so there's something called a physiologic nadir. So at about 10 to 12 weeks of age, almost all human beings become fairly anemic. All right? So if you're seeing a patient roll in the ER about this age, recognize that their red cell volume is going to be low, even by human standards. And the reason that is because they were living on their mom's red cells for the first couple of weeks of life. Their marrow has just started kicking in, and it's this awkward time where their marrow hasn't really started kicking out enough cells, but the mom cells have naturally started dying off. So that's a physiologic nadir. If the baby's premature, it's much more significant because it takes longer for that marrow to pick up production of red blood cells. So your average kid coming in at this range is not going to be robust from a red cell standpoint to begin with. So God forbid it's a trauma with a 10-week-old or something like that. You got to understand, you aren't starting with a lot of wiggle room to begin with. Okay, I'm going to drink a cup of coffee for this. It's not that bad. I think it's actually cool. So here, this side represents what your circulation does when you're in the womb. This side is when you're born or out of the womb. Okay? You can tell the difference because there's a placenta here. But the real difference is, what are your lungs doing when you're in the womb? They're doing nada, right? They're fluid-filled bags that have nothing to do with getting oxygen to your body or getting rid of carbon dioxide. Your mom's placenta is doing all that, right? So your right ventricle is designed to pump blood to the lungs, okay? There's no reason for blood to go to the lungs. And actually, the afterload or the pulmonary pressure is very, 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 very high because the lungs are big sacs of fluid. So the right ventricle pumps. It pumps all this blood out the pulmonary artery. The blood doesn't want to go to the lungs. The blood's got to go somewhere. So it goes across this tube called the ductus arteriosus, which takes all the blood to the aorta. So every time the heart squeezes in utero, all the blood from the left ventricle goes out the aorta, which is supposed to happen. All the blood from the right ventricle goes out the pulmonary artery, but most of it goes across that ductus arteriosus to join the aorta, right? Then it finds its way back to the placenta, so the placenta can do its job and bring it back to the body, okay? Once you're born, you don't have a placenta anymore. Your right heart pumps your blood out your pulmonary artery. There should not be a ductus arteriosus. All that blood goes to the lungs. It gets oxygenated. It gets rid of carbon dioxide. It comes back to the heart to go to the left ventricle to go out the aorta. Normal circulation, okay? So that's what the ductus arteriosus is. So there's three very important lesions I consider ductal-dependent lesions that we're going to talk about briefly. And these are three of a number of what are called cyanotic congenital heart diseases. The reason I bring them up is it'll be once in a career you'll ever get that. But maybe here we might actually see it more than in other parts of the country. Because good prenatal care will detect most heart defects in children before they're born, right? Good prenatal ultrasounds. I worked in North Philadelphia for a long time, where the rate of good prenatal care was fairly low. So I think it's always taught me a lesson, because if you didn't have any prenatal care, and your baby was born, and your baby had one of these defects, no one knew it. And you had a baby, and because, and I'll go into this next, because of that ductus arteriosus being open, baby looks kind of okay. No one knows. But that ductus is designed to close in the first couple of days of life. And once that closes, if you were dependent upon it for your circulation, once that closes, all kinds of bad stuff happens, right? So this is the first week of life. Maybe you could say after maybe 10 days, but once you're past the first week or so of life, this isn't an issue. If this hasn't been detected, this is not an issue anymore, okay? Because that ductus is closed. So if that ductus is closed and you didn't die, it's not your ductus. It's not the heart. So, so there's three. So there's transposition of the great vessels. So I'll just talk about them real quick. Actually, I'll do a picture. Transposition of the great vessels, tricuspid atresia, and hypoplastic left heart. I'll slow down. Normal heart. Okay? right ventricle pumps deoxygenated blood out the pulmonary artery, goes to the lungs. Like I said, oxygenates the blood, returns to the left atrium, left ventricle, goes out the aorta, goes to the body, gives off the oxygen, comes back to the heart, back to the right ventricle to go again. Transposition of the great arteries. When this baby's heart developed, for some unknown reason, the aorta, which should be part of the left ventricle, is attached to the right ventricle. And the pulmonary artery, which should be part of the right ventricle, is attached to the left ventricle. So, if we look back to this, if my aorta, which should carry my oxygenated blood to the body, is coming off the right ventricle, it's going to pump out the aorta, it's going to go to the body, it's just going to come back to the right ventricle, it's going to get caught in a loop. None of that blood's ever going to go to the lungs, none of that blood is ever going to get oxygenated or deposit CO2. And similarly, the blood that comes to the left ventricle is going to go out the pulmonary artery, going to go to the lungs, and come right back to the left ventricle. It's not compatible with life. It's compatible with very, very quick death. But they have this little connector, the patent ductus arteriosus, or the ductus arteriosus, stays patent. So, when the right ventricle pumps out, if you're a red blood cell, you're going out the aorta, you get to here, you can decide, do you continue to the body or do you go across the pulmonary artery? And the same thing happens when the left ventricle pumps, red blood cells can cross back and forth. So, if everything is balanced, enough blood crosses over so that you don't die. Oxygen gets picked up by half your blood, carbon dioxide gets put off, oxygenated blood gets delivered to half the body. Okay? This kid gets into trouble when that closes. As soon as that closes, you have circulation that's parallel to one another, not compatible with life. Oftentimes we, and most commonly we would think this would be a child that would appear like a septic shock child that would come in mottled, hypotensive, tachypnic, tachycardic, and we would treat them like septic shock, but on the off chance that that's the problem, there's only one thing that's going to keep this patient alive. You know what that is?
Surgery.
Surgery is definitely, but you're not going to be able to do that in the ER here.
Open up that.
How do you open it up?
Done.
Prostaglandins, right?
Oh.
So we have prostaglandins in this hospital. So if you have a 4-day-old who's dying in your ER and everyone's scratching their head and you get the history, because history is important, that maybe their prenatal care wasn't the best, give them prostaglandins. The worst case that happens, nothing happens. Best case that happens, baby pinks up. You high-five each other, you go home for the night, and everybody's happy. All right? Then you call me and I say, send the kid to Seattle. It's going to be really fast. All right? So that's tricuspid atresia. That's transmission of the great vessels. Tricuspid atresia, so the tricuspid valve fails to develop, so you don't develop a right ventricle. Okay? So all this deoxygenated blood returns to the right atrium, like it's supposed to. It can't go to the right ventricle. There is no right ventricle. So it all has to go across an atrial septal defect to the left atrium, where all the blood mixes. There's only one tube exiting the heart now. It's the aorta, because there is no right ventricle. So the heart pumps, left ventricle pumps all the blood out the aorta, and again, some of the blood's going to cross over here to get to the lungs, return back to the heart. It's the only way you stay alive. Okay? This is also known as hypoplastic right heart. And then the cool kid on the block is the hypoplastic left heart, which is the hypoplastic right heart in reverse. All the deoxygenated blood returns to the right atrium, goes to the right ventricle, goes out the pulmonary artery, but there is no blood coming out the ascending aorta. So in order to get blood to the body, you've got to shoot across your duct to get blood to the body. Okay? Now, because I find it cool and it's my talk and I get to talk about cool stuff, so I'm going to talk really quickly about the blay-lactasic shunt. So in all of those defects, well, in transposition you actually do what's called an arterial switch, but in the hypoplastic right and left heart, the first procedure is to basically secure blood, a connecting tube between the pulmonary circulation and the systemic circulation, between the pulmonary artery and the aorta. And in the 1950s, there was a surgeon, Dr. Blaylock, and a pediatrician, Dr. Tausig, and they saw these blue babies dying. And there's been lots of movies made about this now, and it's a really kind of cool story. It's also a story of medical experimentation that we couldn't ever do in 2019, but they had these babies. They understood the concept of the ductus. They knew that the ductus had to stay open. I think they even had prostaglandins available to them at the time, but that's not a long-term solution. Even with prostaglandins, eventually that duct is going to close. And in the 1930s, they said, you know what? What happens? I would love to have been in the conversations here. But someone said, what happens when we take the right subclavian artery? So this is the aorta. This is the aortic arch. The first branch of the aortic arch is the innominate artery, which goes to the right carotid and the right subclavian artery. So it delivers most of your blood to your right arm. Somehow, they knew that they could cut this from the right arm, and the right arm wouldn't fall off. There's enough other circulation there. They said, why don't we just attach it to the pulmonary arteries and see what happens? And lo and behold, these kids lived. Because they had this tube that could, depending on the defect, either send blood from the pulmonary artery to the aorta or vice versa. In the modern world now, what we do is called a modified blood shunt. So instead of sacrificing the subclavian artery, we use a Gore-Tex tube, but they didn't have Gore-Tex available for them in the 50s. And insert, this is a stylized, that tube could be inserted anywhere along the way here, but it's sort of a tube that connects as a highway between the two circulations. So it's very cool. Okay. I'm going to talk about rhythms very quickly. Most of the rhythms are the same, but there's one or two that I really want to highlight. So VFib and VTAC, rare in kids. Atrial dysrhythmias, I don't even talk about. Like, if you think it's AFib in a kid, I would guarantee you it's most likely not. I've seen 3 kids with AFib in my life, and all of them were in AFib because they were getting a ton of albuterol, which is the beta agonist, which makes their heart do crazy things. I have never seen a spontaneous atrial flutter or fibrillation kid in my career. But VFib and VTAC, although rare, does exist. A little cooler thing to me is heart block. So I'm just going to review heart block for you. So bradycardia in kids, we have this number we teach in PALS, anything heart rate less than 60 is bradycardia in children, which is true. You have to contextualize it. If your child is a 14-year-old cross-country runner in excellent shape and who is resting comfortably, they may have a heart rate of 48. Please do not start chest compressions on that person. But bradycardia is a problem, okay? Bradycardia is a significant problem in kids also because kids have a higher vagal tone, right? So anything that makes anyone vagal gives you bradycardia. But children are much more susceptible to it. It's also the reason why they teach you in PALS that the number one reason of cardiac arrest in kids is respiratory arrest, right? Because this vagal tone, you have respiratory compromise, hypoxia with increased vagal tone, that's a recipe for bradycardia, and you get these heart blocks or you get just clearly sinus bradycardia. But real quick, just to review how the heart beats, you start at the sinoatrial node, it sends electrical signal, the atria contracts, that's your P wave. It sends the signal now through the AV node into the His-Purkinje system, your ventricles contract, that's your QRS complex, and then as everything repolarizes, you get a T wave, okay? Oh, wrong one. So first degree heart block is just a long PR interval. So there's a conduction delay between when the SA node fires and when the AV node fires off in the His-Purkinje system, right? Usually not a big problem, but notable, patient will come in, they'll be bradycardic, they'll get an EKG, and the PR segment will be long. It's the boring cousin of all the other heart blocks. Secondary heart block we only like because it's got a cool name. The secondary type 1 is called a wanky back, and it is represented by the PR interval keeps going longer and longer, and then you'll drop the QRS complex, right? So longer, drop a QRS complex. There's 2 types. Type 1, a wanky back, it keeps getting longer. Type 2, it does get longer, you just drop a beat. And the cool kids of heart blocks is third degree heart block. And I love this because this is an aha moment. Because I don't know how experienced you all are looking at rhythm strips. Well, if you're nurses, you can look at rhythm strips all the time. But this is a mess. Let's just look at the top one. It's a mess, right? It's a hot mess. Nothing, this doesn't look like that. What's going on here? There's bumps I don't understand. The coolest part about this, though, this third degree heart block means the SA node is firing. The AV node is firing, but the two are doing it completely independent of one another. So when the AV node fires,
you get P waves. When the SA node, when the sinoatrial node is firing, you get these P waves, atrial contraction. The AV node is sitting there waiting for a signal, and for whatever reason, it's not getting that signal. So it waits long enough, and then it fires. And that's where you get your QRS complex started, right? The reason these things look weird is because if you take a piece of paper and you put a little check mark everywhere you know there's a P wave, and you march it through, you'll find that the P wave, this makes it look funky because the P wave is falling right underneath there. And it makes the diagnosis very clear. And all of a sudden it becomes very clear that what you have is third-degree heart block. Works. And then good old sinus bradycardia, the scourge of our existence. And then SVT. So SVT is supraventricular tachycardia. We can get into a complex discussion. If there's any cardiologists in the room, I apologize that I'm simplifying this. But basically, SVT means my his Purkinje system fires, my ventricles contract, and then instead of not being able to fire again, waiting for another signal from above, it just fires itself off, and it gets in a loop, right? And the hallmark is an absence of P waves. You don't see any P waves here. The key element here for teaching between pediatrics and adults is that you can have a 30-month-old who is febrile to 104, comes in, has not drank for a couple of days, a little dehydrated, and have a heart rate of 230, and that be sinus. Very, very, very hard to tell the difference when your heart rate is 230. I think if you saw any adult with a narrow, complex tachycardia like that, you wouldn't even think twice, be SVT. But if those kids can really, because we talked about at the beginning, because the way they increase their cardiac output, they jack their cardiac output with heart rate, you can see sinus rhythms this fast. Now, the difference is, if it's sinus, you don't want to give adenosine, you don't want to shock them. You want to give them fluid, you want to get their fever under control, you want to calm them down, you want to do all those things that are going to lower their heart rate, right? So a trick you can do that I teach people, if you get this, you get an EKG, right? And everyone has a standard EKG. Well, what you probably, if any of you, do you guys in the ER, do you run your own EKGs, or is that an EKG tech? So you run your EKGs. So when you get the EKG machine, it's set at a standard paper speed of 25 millimeters per second. It's a standard, right? You can actually change that. So what I tell people is double the paper speed to 50 millimeters per second. That paper goes through faster as the pen is writing. It opens all this up. So now a heart rate of 200 actually looks like a heart rate of 100. And all of a sudden you can really see what's going on. So as you're standing there with the adenosine, decide if you want to give it. You can do that if you got the EKG. Okay, we're getting to the end of the differences. So central nervous system, basically the head's really what I want to talk about. So what's really great or terrible is that our skull when we're born isn't fused together. We have a hole at the top. And it's important to note, this is the fontanelle. This kid's fontanelle is bulging, okay? I can think of very few things that's a good thing, right? And we don't have a lot of hair at this age and at the end of life, so basically we can see it, that it's bulging, that's a problem. The other thing about the infant skull, because the sutures aren't fused and the bones can expand, you can hide an enormous amount of fluid and blood in the skull. So for cases of like non-accidental trauma or even trauma where there's an intracranial hemorrhage, the kid could be hemorrhaging out in front of you and look fine because the blood is collecting in that brain and it's not a sealed container. We have sealed boxes. We can only expand a little bit in our brain before our brain feels it. This kid's skull starts moving out, and you know, it'll be subtle at first, but you can hide an enormous amount of blood in an infant's brain. So keep that in mind. But more, this is kind of a somewhat of an upsetting picture. Hydrocephalus. So especially if you're born premature, we have these normal ventricular spaces in our brain. Fluid circulates through our brain. Premature infants often have small bleeds that blood collects in the ventricular system and clog up that normal circulation of fluid in the brain. And if it does, it accumulates like this. So sort of a normal ventricular system, maybe slightly generous to a severely enlarged, and that's what you get. And this was actually, hopefully you would never see a kid that would present like this, but so I went to Haiti right after the earthquake, and we set up a mobile hospital, and we were there as a mission to treat victims of the earthquake. But of course, because these people knew that there was a hospital, they were bringing their kids who weren't getting health care otherwise. And there were at least 3 kids that were brought that had the largest heads I ever saw in my entire life. Things that that make this look tiny. But because the skull can expand and the fluid was continuing to accumulate, wasn't draining, the child wasn't actually all that affected, and the skull can grow to an enormous size. Now, luckily, we live in the United States, and there's a treatment for this, and that's a VP shunt. So I'm sure you have adults that have VP shunts, but I feel like there's a lot of kids that have VP shunts more than adults. And it's important to know, very important to history, the child comes in with any kind of neurologic symptoms, anything, to know that this is here, because these tubes fail. The VP shunt is just a tube that drains from the ventricular space down into the abdomen. They can go other places. They go into the pleural cavity or into the atrium itself, but this is the most common. And any obstruction along the way, breakage of the tube, infection in the abdomen, all these things can affect the child. So it's good to know. You can often feel it on one side of the neck or the other, depending on where it's placed. You can feel the tube. It's not a vein. Don't try to put an IV in it. That has happened. Yeah. So now we're saying, ew, let's go to the abdomen. I left all the gross pictures out. But I think the last body system that is really different in kids, again, because of the way we develop in utero, are abdominal problems that you'll never see in an adult, okay? We're going to talk really quick about gastroschisis and omphalocele, diaphragmatic hernia, pyloric stenosis, intussusception, which is hard to spell, and malrotation. So I don't know who Matt Velke is, but I stole his slide, so if you want to tell him, that's how you get in touch with him. But what it shows is basically in utero, and see the timeline, our gastrointestinal tract starts as a single tube, and this outcropping becomes the stomach, which then has to rotate in utero. Again, this is all embryology. And then after that happens, all our guts go out of us, turn 180 degrees, and then come back in to form our normal GI tract, right? So there's all kinds of things that can go wrong with that. Gastroschisis and omphalocele are one thing. So they're differentiated between the fact your intestinal contents are born outside of you. The difference between a gastroschisis and omphalocele is somewhat embryologic, but also an omphalocele has a sac covering over it, where gastroschisis will be the actual elements outside. So again, you deliver babies here. You would like to think that you would know this, but I can imagine delivering a baby with a gastroschisis and not knowing it would be very upsetting. Okay, you're all smart. What's going on in this chest X-ray? Anybody have any idea? Yes. No, you can't answer. So something wrong on that left side of the chest here.
What is that?
What is that? That's small intestine.
Yeah.
All right? So this is diaphragmatic hernia. Now, in 2019, we have lots of cool therapies in utero surgery to fix this, right? Because that's the best thing. The problem with diaphragmatic hernia is this left lung doesn't develop. So these kids are in real bad shape. These are almost, there are some very benign diaphragmatic hernias, but in the true congenital diaphragmatic hernia, this kid needs ECMO to survive, get those contents back, and may not still survive because they may not have enough lung development to breathe even after you fix that. But you definitely have gotten my career where a kid comes in for pneumonia, get an X-ray, and it doesn't look quite that dramatic, but it's like, look at all these bubbles over here. And then you realize it's intestinal contents. My favorite, pyloric stenosis. Very common. Most commonly about 4 weeks of age to present. Projectile vomiting is the pathognomonic term, and when I mean projectile, I mean, we've used the term projectile vomiting. These kids, they're shooting across the room, right? And it's all because this is your stomach, this is the first part of your small intestine, and that's the pylorus, and the muscles are hypertrophied, basically blocking it, all right? More common in little girls than in boys, and maybe boys first, right? The only reason I had a girlfriend who had this, and before I went into medicine, and she had told me she had pyloric stenosis. I never knew what it was, so I really associated with her. But it's about 750 times more common in boys than girls, and they have significant electrolyte abnormalities because they've been vomiting a lot. And then you get an ultrasound, and you see this hypertrophied pylorus, and that's a good way to diagnose this. People talk about feeling the olive, which is a physical exam finding, but I think nowadays we look for it so soon, we don't wait for the olives to develop, and we make the diagnosis earlier. Intussusception, again, like I said, hard to spell. So you can get this at any age, but in kids it is definitely prominent, especially because within the intestinal lining of children are various cells that have to do with your immunity that can hypertrophy when you're sick as a child, and they can act as a lead point. And the best description I have of intussusception is that if this is my small intestine, that it kind of telescopes in on itself like that. I think that's the best description I have. And you can see that that's what they're trying to show you in this cross-sectional view here, the intussusceptum going in. That's what an X-ray is going to look like, because it's going to be obstructed proximal to it. And if you get a cool cross-sectional, you see all the layers of intestine telescoping on itself. And then find malrotation. So I told you your guts are supposed to go out, twist, and come back in. They don't do that right. They can actually twist inside of you. These are all surgical emergencies. These are things we can't wait to, diagnose. And you get malrotation with what's called a volvulus. So you can see this in the contrast here is this is normal intestine. This is the stricture point, and that's the volvulus that's developing. These are risk of perforation and of death. Okay? All right, so that's the anatomy and physiology, and then I just thought we talked about a couple of cases. Yeah, perfect. All right, so I picked these cases because I think they're things that we see kind of commonly, maybe, and maybe one or two, like I say, might not be common, but I would say common enough, and they may change the way you look at some of these kids. Okay, I can give you any more history you want, but case one is a 4-week-old infant. Not latching to feed in the past day. So when you're getting a history in a pediatric patient, things like how's the baby feeding, how's the baby breastfeeding, these are clues that something is going wrong. We did survive to be on Earth because we feed. That's an important thing for us to do. It's very, very innate for us to do. So a baby who was feeding and not, something's wrong, okay? But otherwise, it doesn't seem all that bad, right? These are the emission vitals. Heart rate's 145, breathing 35 times a minute, blood pressure 78 or 45, SAT is 99% of room air, and temperature is 100.8. So I think the toughest thing about pediatrics is to put this into context, right? You do it for a while, you can look at these, and you understand immediately what's normal, what's abnormal, what's not. I think for people who are not primary pediatric providers, this is more complicated, right? And I recognize that. So from my point of view, a little bit tachycardic, maybe slightly tachypnic. I would say blood pressure is okay, that's okay, and I would consider this a fever. Consider anything over 100.4 a fever, okay? So first impression, just knowing that, do you think this is an emergency? How about ER nurses? Emergency? Yeah, why is this an emergency?
Not easy.
Not needed, okay? But I'll challenge you. Looks well hydrated, not cachectic, hell, is even slightly vigorous. Still an emergency? Yeah. So this kid has meningitis, right? Now your average adult with bacterial, I'll even say bacterial meningitis, your average adult bacterial meningitis is not going to seem exactly the same, right? The learning point from this case is that infants, usually we use 8 weeks as a cutoff, but we lower it. But a 4-week-old with a fever is a medical emergency until proven otherwise. They can have fevers for lots of reasons that are not meningitis, but sometimes it's actually surprisingly hard for them to spike a fever. So if they've got a fever, something is going on. And they can look completely fine and have rip-roaring bacterial meningitis. So if you have a 6, 5, 4, 3, 2, 1-week-old with a fever, that requires a full sepsis workup until proven otherwise. Okay? Initiation of antibiotics as soon as possible, because that's going to make all the difference in this kid's future. This is the kid who can look like that in the ER and be dead 12 hours later. How scary is that? Okay. Case 2. Now this one's 4 months old. Was fine, eating normally, but has 12 hours of vomiting and diarrhea. Has now pretty lethargic between feeds. These are the vitals. So this is pretty tachycardic. Breathing a little bit fast. I would argue this is borderline on the low side. Saturating well, low-grade fever. Okay? So what do you worry about in this kid? So I heard a couple things. I heard hypovolemia. Anything else? Septic shock, maybe?
Yeah.
Yeah, all right. So I put this case up there because the point here is, in this age group and younger, it doesn't take much to get you really, really dehydrated, right? So if I had a picture of this child would look incredibly dehydrated. Other important historical points you want to find out about a dehydrated baby: they've been making the same number of diapers. Moms are incredibly good at being able, and dads, shout out to dads, are incredibly good at being able to tell you about diapers often. If it's a lot of diarrhea, though, it gets a little complicated. Tears. If the baby screamed bloody murder, there's no tears. That's concerning. But knowing nothing else, seeing that heart rate would get my attention. And again, contextual. Kids got a higher fever, screaming bloody murder because you're trying to stick them with an IV, and it's got a heart rate of 195? Yeah. But is laying there kind of lethargic at 195? That's absolutely danger sign, right? And lethargy in general is an important thing. Children should almost never be lethargic. They're allowed to sleep. They're allowed to rest. So lethargic is, I'm going to start metaphorically poking you with a stick, and you're going to be like, 4 months old, no 4-month-old's going to take that. So, and if you want to test that theory, put an IV in them, see what they do. If they don't fight you, something's not right. Okay. Case 3. 4 days old. Chief complaint, breathing fast, eating completely normally, sweats with feeds. Okay? Kids don't sweat. So, sweating with feeds, concerning. Heart rate 205, respiratory rate 45, blood pressure probably normal in a 4-day-old. Stat, 85% on air, temp a little bit cool. So I heard cardiac activity. What else could this be? So is that Dr. Noble said septic shock? Yeah. So 99.9999% of the time, this is a kid with septic shock. Probably group B strep sepsis. Acquired through transfer to the birth canal and is septic. However, at 0.001% of the time, this is something wrong with this kid's heart, right? And I do take that seriously, but heart rate is 205. I take that very seriously. Again, not SVT. If this was a 50-year-old man, you'd probably be putting paddles on him and getting ready to dizzy. But 205, this is concerning. So what do you want to do about that? How do we fix that? Get some oxygen, right? What can that do? Oxygen's good.
Well.
Is there ever a situation occur where oxygen is bad? Right? COPDers, do they sometimes they get bad. They're old. So young people. Sorry. So oxygen shouldn't be bad for you, right? So I'm going to say, dutifully, you see this and say, well, I got to fix this. Maybe if I fix this, some of these things will get better. So I put the kid on a non-rebreather 100%. The stats go up to 92.
Woo-woo.
Good?
Yeah.
You happy? Right? Heart rate goes to 225.
Ooh, okay.
Blood pressure drops to 50/20. And respiratory rate goes up to 60. So that's not good. So why would that happen? Yeah, well, I'll tell you what happened, right?
I don't know.
Now, Eric, you cannot answer any questions. Right? This is my show.
I know.
Each salad. All right. So what happened? So we go back to, remember we talked about that ductus arteriosus, right? Ductus arteriosus is a highway between blood going to the lungs and blood going to the body, okay? If you're a red blood cell and you reach the ductus arteriosus, your decision to either go to the body or go to the lungs is all based upon the resistances downstream that you're seeing, okay? So, oxygen is a very potent pulmonary vasodilator. So, I put oxygen on this kid. I decreased afterload to the pulmonary circulation. So now, as a red blood cell, I want to go to the lungs. More of me, I'm bringing more of my friends. We're all going to the lungs, which is awesome because we're going to pick up oxygen. Our stats are going to go up. But there's only so many of us. So if all of us are going to the lungs, great, we got oxygen. None of us are going to the body. So we got our stats go up. We're all high-fiving, but the kid dies because all of us have well-oxygenated blood, and none of it is going to the tissues of the body. Okay? So in sinus heart disease is the only physiologic place that I can think of that oxygen really can be quite detrimental to you. And it's not in all defects, and it's more complex in this discussion, but understand that this is the one case where it might be bad, and what's even harder as any kind of clinician in the room, when you put a therapy on and it makes things worse, you have to recognize and question what you're doing. But if you don't understand this anatomy, you've never heard about this anatomy, you'll never even think to ask the question. Okay?
What did the lung sound like when you're listening to that?
So, great question. So, unfortunately, this kid, ironically, is probably getting just a little too much pulmonary blood flow and not enough systemic blood flow at the beginning, which is why they're tachycardic and hypertensive. But their lungs may sound completely clear, completely fine. It's just that your body only has so much oxygen to deliver, right? And in this kid, more of it's going to the lungs than the body, and the body is starving. The body is in shock because it's not getting the oxygen it needs. But the lungs are not diseased, right? And if this is septic shock, you might get away with kids having some abnormal lung sounds, but no guarantee. And then the other kicker to all this, the heart sounds, some of the worst congenital heart disease I've ever heard don't have a murmur to speak of. Because when the holes are so big, there's not too many murmurs.
So their skin is, it's 95, so the skin.
So the skin's cool.
No,
The body's saying, I'm in shock.
so you see.
I'm doing all those things shock has to do.
Right.
The important thing, though, we're talking no point is I don't ever want anyone leaving this lecture thinking that this is the common thing. This is septic shock until proven otherwise. You give oxygen, you give fluids, you give antibiotics, you give pressors, you send cultures, you do all those things. But 1 in a million is going to be going a little bit south, and that's where you have to recognize the difference. And if you don't know, and it's not easy, let's say you're someplace where you don't have a lot of tools available to you. You do all things for septic shock, and you start prostaglandins anyhow too. Right? So like one downside of prostaglandins, kids get a little bit of apnea sometimes, but this kid's going down the tubes, you're probably trying to control that kid's airway to begin with. Start the prostaglandins. There's literally no other downside. Okay. Case 4, 6-month-old, a little older, runny nose and cough for 3 days, breathing fast, eating well. Those are the vitals. Pre-tachypnic. Anything exciting about this case? He's sick. And really, that's what this case is. He's got bronchiolitis. This is what pays my rent. This is the kid that in the month of, well, up here, the months of September through July, and there's all kinds of viruses, most of them we can't even detect, but RSV or respiratory syncytial virus being the most common, and this kid is lungs are going to sound wet, going to have a junky chest x-ray, is going to be breathing fast, going to be working to breathe, and we're going to have to fix him through it. Almost done.
Yeah, a couple more minutes.
Yep. 9-month-old, 2 days of vomiting, stopped taking oral feeds, lethargic between feeds, and I've got these vital signs. 9-month-old. So tachycardic, breathing a little fast, blood pressure's okay, but afebrile. Hypovolemic, right, so we're vomiting, but the question is why. Now, when I think of kids, I always think about they're infectious until proven otherwise. But the absence of fever makes me think about other things other than infectious. So now, one thing we're very bad at doing in pediatrics is a good abdominal exam. I don't know why, mostly because kids fight us when we're doing an exam. But this kid, if you were to feel their belly, has something hard in their belly, surgical abdomen. And this case was designed to represent an intussusception. They don't really look necessarily like anything dramatic, but then when you feel their belly, you're going to figure it out that something's really going on. And the key is they're not febrile, they're pre-tachycardic, they're lethargic. That's a big problem. Okay. 3-month-old. It's been vomiting for 2 days, taking nothing orally, lethargic, stridor and wheezing on exam, and has those vitals. Where do you think's going? Well, what jumps out at you? Heart rate, temp, right? So, if this is a 50-year-old guy, what are you doing here? Cardioversion, right? This is a kid who's sick, dry, angry, stridor, wheezing. We give him albuterol treatment, and he's got a fever. All those jacked his heart rate up. So this is just a sick kid who has a severe sinus tachycardia, and you don't want to go down the SVT pathway unless you prove that this is going on. And because his blood pressure is okay, you don't have to run to shock him. He's in stable. If this is SVT, he's in stable SVT, you can assess it a little bit. If he was hypotensive, you might have to err on the side and treat it as SVT until you can prove it otherwise. And then I have one more case, the last one. 5-month-old, has been vomiting for 3 days. Again, that lethargic thing. Those are the vitals. What jumps out of those vitals? Heart rate very high, kid's very cold. 5-month-old, very cold. And very lethargic. So, could be, because of this, could be hypovolemic shock, right? Could be sepsis. Kids get cold when they get septic. Blood pressure is a little bit old. There's other keys here. Now I'm going to get a little bit more of the history. So the history is, this kid's rolled into the ER, it's 8 o'clock in the morning. Mom is a nurse at another institution. Her boyfriend was watching the kid overnight, and the kid fell off the couch at 5 months old last night. Right? So that's the classic story. Every damn kid I've ever seen who is non-axonal trauma has fallen off the couch at some point in their very brief months of life. So this is represents non-axonal trauma. So this kid has a huge intracranial hemorrhage that's being hidden because their skull can expand, they're hiding that blood in them, and they look sick, you understand something's wrong, but the amount of bleeding that's going on in this kid would have killed us a long time ago. And this kid's still hiding it. So you've got to think about that and assess that as quickly as you can, because if we don't do something about that, even with our skull expanding eventually, we can bleed our entire bloodline into our head. So I think that's finishing on time, and thank you for listening. I'm here for any questions, and please, we can always help. You can go help pick your product 24 hours a day at this number. We're available. So especially for my friends in the ER, if you ever need us, please call us. We'd be more than happy to help. All right? Thanks so much.
Thank you, guys.